weekly Gecko session, which this week is devoted to patient blood management. And it's a great pleasure for me to co-chair this session with Professor Vernon Louw, who needs no introduction. But to those of you who have joined us for the first time, he heads the clinical hematology unit of the University of Cape Town, to which he chairs, and also runs a very effective patient blood management program. Now, the Gastroenterology Foundation of Sub-Saharan Africa has associated itself with this important topic, and we've put on a couple of advisory groups together, and we look forward to a guidance document, which we hope will be published in the new year, guiding clinicians of all subspecialties on how to replace blood with iron effectively. So, Vernon, it's a great pleasure to have you here today, and I look forward to two case presentations, which we will co-chair and discuss. Thank you.
Thank you so much, Chris, and thank you very much, Karen and Cheryl, for your help with the organizing. I'm going to go straight to my presentation here. So, to understand patient blood management, one has to understand the physiology of iron deficiency. So I'm taking a slightly different approach today, where I want to discuss the physiology of iron and its treatment, and also the diagnosis of iron deficiency, making use of some cases. And because this is the Gastro Echo meeting, I've chosen 3 gastroenterology type of cases. But I think you'll find that the principles embedded in each case is really those principles that underpins the principles of patient blood management. So for those who've seen my talks before, you will recognize some slides. Some may be repetition, which I think is always good, but I hope there will also be something new. But I often start with this slide showing that iron deficiency is the #1 health problem in the world. In terms of frequency, and it affects literally 1 out of 3 people in the world. And in lower income countries, it's much more common. In South Africa, for instance, up to 1 in 2 women are affected. It's the #1 cause of anemia. In 50% of all anemias, this is the actual cause. And it's the most common health problem in pregnancy. And this slide just shows a study from the Western Cape, looking at both patients from state and public sector and private. You can see here almost 40% of all participants, if you include females and males, were iron deficient. And in Black Africans, there was a prevalence of 56%, in 50%, and in females in general, 56%, which is quite remarkable, a huge number. So basically 1 out of 2 female patients that you will encounter have iron deficiency, and very important to know about it and to recognize it. So what will we do today? We're going to focus on some cases and see how we can apply iron metabolism practically. See, I've got a new spelling there, to the testing, diagnosis, and treatment. And then at the end, we're going to solve the cases. And I want you to think alongside me. So that first sentence can really not be overemphasized. All body cells need iron, not just the red blood cells, not just the bone marrow. We'll get back to that. And you can see how much iron a normal human body needs. And iron has a lot more functions than just making hemoglobin and carrying oxygen. And I've underlined energy production. And hopefully in the next hour, you will see why this is so important to me. If we look at the major steps of iron metabolism, you don't have to memorize them now. I hope that by the end of this talk, you will remember them with ease. We'll go through them one by one. And we'll start with the first important step, and that is of iron intake. And I want to start here with a real case of a patient that I saw in January 2018. She's a colleague of ours, working in the health professions, 25 years old, and I gave a history of total lack of energy. She was previously a keen runner. It was affecting her work. She was complaining of hair loss, headaches, craving for sugar, Coca-Cola, chocolate chips, ice cold drinks, and also developed a depressed mood. She gave a history of severe menorrhagia as a teenager, but no other personal family history of bleeding. was eating a normal diet, regular red meat, chicken and fish. And on examination, she had mild vitiligo and non-specific diffuse abdominal discomfort on palpation. There was a history that she was previously diagnosed in 2013 with pernicious anemia, for which she was receiving regular B12 injections. And this was escalated to 2 weekly because her energy was not coming back. And in 2016, they placed her on oral iron for confirmed iron deficiency, and then changed to a different formulation a couple of months later, but this did not seem to work and improve her energy. She also was found to have Helicobacter pylori at the same time in 2013, and a repeat gastroscopy in October 2017 still showed chronic follicular gastritis, still again Helicobacter pylori positive, and she was given eradication therapy. And this was her blood results. Normal white cell count, hemoglobin 12.9, which would be normal according to the WHO definition for females. That is, anemia would be less than 12. MCV and MCH normal, platelet count 210. You can see then the serum iron is 12, which is low. Transferrin 2.6, which is normal. Transferrin saturation of 18%, we'll come back to that, and a ferritin of 29, which according to the lab's reference range was normal, but we're going to debate that later. She had normal thyroid function tests, and a celiac screen was also found to be normal. So the questions that arise from this case is, what are the potential contributing factors to iron deficiency here? Why is she not responding to treatment? Can we attribute the symptoms that she's having, all these funny things like hair loss and nails that break and headaches and these things, all the cravings, can we attribute that to iron deficiency if she's not anemic? And should you treat iron deficiency in the absence of anemia? So if we look at iron intake, it's not just about how much you take in, it's also about the form in which you take it in. And a Western diet contains about 10 to 20 milligrams of iron a day, mainly consisting of heme iron from meat, poultry, and fish, as well as inorganic iron from meat and vegetables. And when iron is taken in, it first needs to be removed from the food in the stomach by hydrochloric acid. And for those of you working in gastroenterology, I saw a couple that are not gastroenterologists in the room. So just to say, the pH in the stomach is really low, and it's similar to battery acid. So it's quite impressive what it can do. So it can dissolve stainless steel at that level. And of course, if you've had a gastrectomy, gastritis, and we know that that is especially important, atrophic gastritis in the elderly, pernicious anemia, Helicobacter pylori, all of these have been strongly associated with the development of iron deficiency. But one that is often not thought of or considered is PPIs, proton pump inhibitors, is a very common blocker of iron and iron absorption. And then bariatric surgery, except perhaps for banding, will also lead to problems with iron absorption. And I just want to point out this article that I thought was quite interesting. It was a specific study from the European Hematology Association looking at the role of autoimmune gastritis, Helicobacter pylori, and celiac disease in refractory or unexplained iron deficiency. And you can see the typical age, younger age people in this case, 119 of the 150 were female. And in this group, they found that 5% had celiac disease, 27% autoimmune atrophic gastritis, and 22 of those patients of the 40 had low B12 levels. And then H. pylori was seen in 19%. And the refractoriness to oral iron was found in 100% of celiac patients. So it just tells you, doesn't help if you give oral treatment there. 71% in those with pernicious anemia, and 68% of patients with H. pylori and iron deficiency did not respond to treatment. So in this case, there are already, we can see the 4 factors that are contributing: pernicious anemia, H. pylori, PPIs that she started using herself and medicated herself with, and then menorrhagia. Then we'll go to a famous second case of this, well, ex-couple, I guess. And Angelina Jolie eats a normal diet, but her ex-husband Brad Pitt is a known vegan. And the question is, which of the following would you advise each of them to take? So Angelina, would you advise egg yolks, tomatoes, tea, spinach, red meat, or iron supplements? Because they came to see you now to get advice on a good diet. And the same question for Brad Pitt. And I want you to think about this as you listen to what's coming next. If we think about iron absorption, we said earlier that you take in 10 to 20 milligrams of iron per day. And of that, the heme iron is very well absorbed, 30%, but the inorganic iron is very poorly absorbed. So your net absorption from the 10 to 20 milligrams that you're taking in per day is only 1 to 2 milligrams. So it's only 10% of what you take in will actually go into the system. And if I ask this question, you know, when I speak to a live audience, what would you advise? What food should people eat? Spinach is usually the first answer I get, or at least the second after red meat. The thing is, who taught us this? So let's look at it. Cooked spinach does contain a lot of iron. If you look at lean steak at the very bottom, cooked spinach second from the top, looks like it contains a lot of iron, but it's very, very little of that is absorbed, as you can see in the blue. And if you go and calculate how much spinach you need for your daily needs, you can actually go and make a nice calculation there. You actually need to take in 2.2 to 4.5 kilograms of spinach per day. So you will have difficulty maintaining a vegetable garden that can look after your whole family's iron using spinach. And the reason is that spinach, like and many other vegetables, are very poorly absorbed. It's very difficult for the body to remove the iron and get it into the system. And that is also true with other foods that can block iron absorption, such as phosphates, tannates, and phytates, all things that you find in cereal. If you just think of a normal breakfast, let's say a breakfast without meat, most of the things that you find in a breakfast meal, excluding meat, would block iron absorption. Anything containing calcium, like milk, for instance, or calcium supplements, eggs. Eggs contain phosphatin, which will block iron absorption, tea and coffee. And that's why it is typically recommended, if you take the old ferrous sulfate, that you should take it on an empty stomach. There are now new formulations that you can take with food. But if you take ferrous sulfate, it should be on an empty stomach, if at all possible, because otherwise a very small amount will be absorbed. So you can have your tea and coffee, but keep it for tea time, not for whenever you take in your iron supplements. If you do want to increase your iron absorption, a small glass of orange juice or just eating some oranges will increase absorption by 50%. But tea and coffee will decrease absorption by 50%. So vegetarians, vegans will have a problem with their iron intake. Anybody who's not taking enough meat, often in our setting from people coming from low social or poor socioeconomic circumstances, it's often a challenge to get enough iron into the diet. Case number 3 is another patient and another colleague, also a real case that I saw. Both of these are patients of mine. 36-year-old medical doctor. She presented in February of 2018, just around the same time as the other patient, same month actually, with a 4-week history of gnawing, epigastric, and back pain. She started herself on a PPI and then started to have colicky low abdominal pain and admitted via the ER at Panorama Mediclinic, where I was working at the time, rolling around in pain. She had nausea, but no vomiting or diarrhea, and a previous medical history, hypertension, plantar fasciitis, and again, menorrhagia since menarche, and she'd never used iron supplementation before. She was diffusely tender over abdomen, but especially so in the right iliac fossa, and had no hepatosplenomegaly. Her blood results showed a leukocytosis with a neutrophilia She was mildly anemic, but a normal MCV and a borderline MCH. Her platelet count was raised. She had a raised ESR. There was a normal lipase, slightly increased alk phos gamma GT, and mildly raised ALT. Kidney function normal, CRP was high, B12 folate normal. And then you see the interesting results here for the iron. Serum iron is very low, transferrin was low, and then the saturation 5%, and the ferritin, according to the reference ranges given, was actually increased. CT abdomen revealed a perforated terminal ileum, and an ileocystectomy was done. And the histology was consistent with Crohn's disease with marked mesenteric inflammation. So again, the question is, how does one interpret her iron results? Can you diagnose iron deficiency when the ferritin is normal or high? And how will you treat a patient like this if iron deficiency is confirmed, with diet, with oral, or with intravenous iron? And I'm going to come back to that later. But to understand all these cases, we now really have to zoom in and concentrate on how iron metabolism works. Because if you understand this, you understand the principles underpinning, as I said before, patient blood management and the management of almost any patient with iron deficiency in or outside the context of infection, inflammation, etc. So let's go back to the duodenum where iron is absorbed. And as it goes in, you'll see that some of the iron represented here by these little blue dots will enter the circulation by they will move through the enterocytes in green. And some of these will stay in the enterocytes, while some will pass through and be loaded onto transferrin, the little two-seater canoes on which iron is carried. And transferrin, and you can hear it in the name, trans for transporter, ferrin, carrying ferric, 3+ iron, can carry, like any canoe can take, the two-seater canoe can take 2 passengers or 1. And the same is true here, and will transport the iron through the plasma. And why is it important? Because so-called free iron is toxic. There's not really a thing such as free iron. If iron is unbound to transferrin, we call it non-transferrin bound iron, and that iron will link up with other proteins and damage a lot of things around them. And because it's so toxic, it has to be carried by a special carrier protein, in this case, transferrin. So transferrin will circulate, take the plasma all around, and the main receiver of iron from the transferrin will be the bone marrow, where it will be incorporated into hemoglobin. Through this process, the red cell precursors will take up through transferrin receptors the iron, and it will incorporate it into hemoglobin, placed into these little hemoglobin bags we call red cells, of which 200 billion a day are produced, and they will then circulate for 120 days, after which they will be recycled when they reach old age in the spleen, in the macrophages, and from the macrophages the iron will be recycled into the circulation. Now you can remember we said only 1 to 2 milligrams a day was absorbed from your diet. And you can see that the most important source of iron in your system is actually iron from recycled red blood cells. So the more anemic you become, there will be less to recycle, and this will progressively become depleted. Iron can also be stored, and that happens mainly in the liver, in ferritin. And ferritin, if you think of the tin as a literal tin, is a little storage protein, beautiful, wonderful thing consisting of these 24 subunits, nicely arranged in a spherical capsule. Each one can take about 4,000 iron atoms, and it is found in all human cells, but mostly in the liver, spleen, and the bone marrow. Importantly, it's an acute phase reactant, so it will go up. The levels will go up in inflammation, and it gives us a good indication of iron stores. So if you think of your iron results, whatever you find there will tell you how much stores you have. So you've got total body iron, And then you've got storage iron. And the storage component is usually, in a normal person, about 500 to 1,000 milligrams. But to put that into perspective, one single pregnancy requires an extra 1,000 milligrams of iron. So if your ferritin is between 50 to 100 as a woman, you will probably deplete your whole iron store. Well, if you're at 100, you'll deplete it all. If you're at 50, you're not going to have enough, and your baby will become iron deficient. So ferritin is very useful as a test when it is low, but much more difficult to interpret if it is high. Because you then need to decide, is it iron overload? Is it liver disease? Is it an acute phase response? Or is it an acute phase response plus iron deficiency? So not that easy. And we're going to, by the end of this talk, you should be able to do this with ease. Iron is also lost in women, mainly through menstruation, at a rate of about 1 milligram per day. That's about 30 milligrams a month. You remember I said in the beginning, one absorbs 1 to 2 milligrams of iron a day. The 1 is for men, the 2 is for women. Women compensates by absorbing a little bit more. There's a feedback loop to tell the gut that is needed. But it still places a woman in a very precarious situation if she has any excess in menstruation. She easily becomes iron deficient. But normally iron is lost passively also through desquamation of these enterocytes in the gut that contains ferritin with some iron in it. And you take in about 1 and you lose about 1. In women, you lose 1 milligrams a day through the gut and 1 milligrams a day on average through menstruation. Now, we have to zoom in now on the control room area, because there's only one place where iron metabolism can be actively controlled, and that is at the level of absorption. The body cannot increase or decrease its iron excretion. That sort of just happens. But it can increase or decrease iron absorption. And to understand this, we have to look at the enterocyte and what happens at that level. So let's start with the iron coming in your food, which is mainly in this ferric form, Fe3+. For those who've not heard me before, the way you remember ferric and ferrous and which one is 3 and which one is 2, you just listen to the sound it makes. Ferric sounds like 3 and ferrous sounds like 2. So ferric 3. And you'll see that all the names of all the molecules tells you which one is carried or stored. Ferritin would be 3+, transferrin 3+, and so forth and so forth. You'll see in a moment. So it comes in the food in Fe3+, but it has to be changed to Fe2+, because you've got this thing called DMT1, which is the divalent metal transferase 1, and the di in divalent tells us that you're looking for a 2+. So the first change is from 3+ to 2+, and that happens through a process of reduction, which is done by this thing called ferric reductase. And what does reduction mean? It basically means that an electron is added. So the positivity is reduced from 3+ to 2+ after adding that electron. And why do I focus on that? Because it's important, because the Fe2+ will come into the enterocyte and will form this labile iron pool with all this Fe2+ with extra electrons. And those electrons are very, very damaging to all organelles in the cell. It can damage DNA, mitochondria, lysosomes, membranes, whatever you can think of will be damaged by the electrons through free radical formation. So you need to do something with that 2+ to get it safe. On the side here, heme iron comes in and also adds to that same pool. Fortunately, the cells, like every cell in the body, can store excess iron safely in ferritin, where the 2+ is changed back to 3+. But now, critically, apart from the storage in ferritin, iron goes to mitochondria. And this is something very important that I learned too late in my career and that I want to share with you, that there's at least 5 enzymes in the ATP production cycle that are iron dependent. And remember that the bone marrow will always stand first in line to take all iron, and all the other organs will come second. But if the other organs don't have enough iron, they're not going to be able to produce enough ATP. And this will lead to all the symptoms of iron deficiency anemia, even if the patient is not anemic. And this ATP is critical for the development of the fetus, in the heart, in the brain, and in the muscle. And maybe on another occasion, I can talk to you about my greatest passion, which is iron deficiency in pregnancy, and show you how many cognitive developmental defects the baby can develop if the mother is iron deficient, which remains until, and this is how long the research has been, or the follow-up has been, at least 25 years of age. So critical for all pregnant mothers to make sure that not just their hemoglobin, but also their iron levels are adequate. So one of the first key learning points today is that iron is needed in every cell of the body, and iron deficiency without anemia can give you all the symptoms of iron deficiency anemia. And we call that non-anemic iron deficiency, or NAID, something not adequately recognized before, but it's now coming to the fore. This article that was published in the American Journal of Hematology, and the names of the people here are all the big names in anemia and iron around the world. Clara Camashella, for instance, she typically writes the New England Review articles on iron. And they have come out with this important statements. First, they came out with a definition for iron deficiency. And look at this carefully with me. Iron deficiency is a health-related condition in which iron availability is insufficient to meet the body's needs, and which can be present with or without anemia. In the abstract of this article, it says iron deficiency, even in the absence of anemia, can be debilitating and exacerbate any underlying chronic disease, leading to increased morbidity and mortality. And it has been shown clearly now in heart failure, for instance, that there's a mortality effect of iron deficiency, even in the absence of anemia. And this is really about a third of the patients I see in my small private practice come with iron deficiency. And I promise you, they have debilitating symptoms despite having normal hemoglobins. And they send to me because people can't explain the symptoms because the patient has a normal HP. So what can be the problem? The iron deficiency is critically important. And it's important to understand that anemia is the end stage, the ultimate consequence of iron deficiency. In many patients, also those with chronic inflammatory conditions. And they say here, the same article, the medical field should recognize iron deficiency as a clinical condition distinct from anemia. If you can take that home today, you know more than what I think 90% of doctors that I teach know before the lectures start. Next step, of course, we said was that iron will be taken up, and it goes out from the enterocyte through this iron door, through ferroportin, port for door, and it's obviously 2+, it's ferro, and it is loaded onto transferrin, but that's a 3+. Or transferrin can only carry 3+, so it's got to be changed, and there are these molecules called the hepcidin, which gets its name from Hephaestus, the old Greek god of metals and fire, which is quite appropriate because it takes the electron, the fire, out of the Fe2+, and oxidizes it to become 3+. There's also ceruloplasmin in the plasmin that can do the same, just in case Hephaestus missed one. And if there's excess 2+ iron, like what you see in patients with iron overload, or when you take ferrous sulfate, then non-transferrin bound iron can enter the circulation and cause damage on its own. So iron absorption is regulated by this special molecule, and we'll have the 20th anniversary of its discovery soon, called hepcidin. Hepcidin is the key regulator of iron absorption. The hep in hepcidin refers to heparin because that's produced in the liver, and it's got a critical role in preventing iron overload. If hepcidin is high, it blocks, it's basically the key that blocks this iron door, and the cell literally internalizes the ferroportin, takes it away so that iron cannot enter the circulation. And that's a normal physiological response to infection and inflammation to prevent iron from getting to microorganisms that live on iron. But it also happens after any kind of tissue damage, surgery, cancer, all of those conditions will have high hepcidin levels. If it is low, the ferroportin, the doors will be open and available and iron can be absorbed, and that's the body's normal response to iron deficiency. Or if there's a genetic problem that leads to low hepcidin production, you get hemochromatosis, which leads to increased iron absorption. And if there's inefficient erythropoiesis in the bone marrow, there's a signal that goes back to say, decreased hepcidin production, send us more iron, and then pathologically you get iron overload. So again, if hepcidin is high, ferroportin is locked and absorption is low, and the opposite if hepcidin is low. So it's logical then that in simple iron deficiency, hepcidin will be low, and the ferroportin, represented by these black little circles, will be open, and you can treat a patient with oral iron. But note that ferroportin is not just present on the enterocyte, but it's also present in the liver, in the spleen, on the macrophages, and also macrophages in the bone marrow. And if hepcidin is low, all these ferroportins will be open, and iron can also be recycled. But if it is high, as in infection, inflammation, cancer, heart failure, surgery, all the ferroportins are blocked. You cannot absorb it, you cannot recycle it, you cannot release it from the stores, it's not available. And then you develop anemia of inflammation. That's the new term for the old anemia of chronic disease. So oral iron absorption is going to be blocked. And you'll see on the right, I also show you, this is the term for iron-restricted erythropoiesis, meaning there's iron there, but it's not available, can't get it out. So in these cases, you need to bypass the system and use intravenous iron or a form of iron that can be absorbed hepcidin independent. I'll come back to that. So now, how does all this help us to diagnose iron deficiency? So we said earlier that ferritin is a very useful tool in simple iron deficiency. So if you don't have inflammation, a low ferritin means the patient is iron deficient. Another question is, what level are you looking at? And here, I make a very big point of the fact that the reference ranges that is used by or are used by our labs are incorrect. And Clara Kamashela, in a last article in, I think it was in the New England Journal of Medicine, strongly emphasized this point, that the reference ranges for most labs were generated making use of young people, young women, and blood donors who we know are often iron deficient. We can't use it. As an example, if you use a typical South African lower cutoff level of 15, the sensitivity of that is only 57%. And the specificity is 99%. So what does that mean? It means that you can be 99% sure that the patient has iron deficiency, but you will miss 43% of cases. If your ferritin is less than 30, the sensitivity is 92%, and you only lose 1% specificity. You'll miss only 8% of cases. So the generally acceptable cutoff now, also in that article by Kamashela, is to use a cutoff of 30. I know there is a gastroenterology guideline from Europe that suggests using a cutoff of 45, which I think is probably not unreasonable in the gastroenterology environment. But as a general rule, if your ferritin is less than 30, you can be sure that your patient is iron deficient, and it's totally defendable or defensible to treat that patient with iron. But we said that ferritin is an acute phase reactant. And this is a problem in the elderly, where ferritin is often high because they've got many other diseases or comorbidities, such as liver disease, maybe infection, inflammation, maybe renal problems, tissue damage, cancer, or in any patient with any of these conditions. So what do you do if the serum ferritin is higher than 30 due to one of the above, how can you diagnose a concomitant iron deficiency? Obviously, any patient with any of those conditions can also develop iron deficiency. And this is where you use your transferrin saturation. And don't confuse the saturation with transferrin. They're linked, but it's not the same thing. And I'll show you what I mean. So if you look at the transferrin, just that we said was the little two-seater canoe that carries the iron around, it's measured in the lab as total iron binding capacity, or another term would be transferrin saturation. As a student, this confused me greatly, and I'll explain it now, and you'll hopefully never forget it. What it basically tells you is that circulating transferrin, if you count all the canoes together, is usually about 1/3 saturated with iron. In other words, about 1/3 of all the seats are filled on all these little canoes. So let's take an example. Let's say you've got 5 canoes here, each with 2 seats. What is the total iron binding capacity? Well, there are 10 seats, so the carrier capacity of this transport system is 10. So let's say we've got 4 iron molecules sitting on the seats. Then the serum iron is, and this is simplified, but it works for me all the time. It's 4. So what is the saturation now? Well, 4 out of 10, 40%. That's your saturation. And we said normal would be about 3 out of 10. But somewhere between 2 and 4.5 out of 10 would be normal. So here's another example. Iron binding capacity is 10. There's only one. Sat is 10%. That is obviously low. So if we look at our diagnostic tests, if you take hemoglobin, if you use hemoglobin in isolation to detect patients with iron deficiency, you'll miss about 40% and more, depending on the population you study of patients with iron deficiency. If you use your transferrin saturation, which reflects iron available not only for erythropoiesis, but also for other tissues, if it's less than 20%, that is low. And your serum ferritin, we said, reflects iron stores, but you cannot use it on its own in any of these inflammatory conditions unless it's less than 30. So what do? Well, we said the saturation is low in inflammation, heart failure, tissue damage, etc. But it can also be low if the patient just has anemia of chronic disease. So how do you work this out? So let's take some examples. So if your ferritin is 30 to 100 and the SATS is less than 20, that is iron deficiency. Okay, and plus anemia, of course, if the HP is low. But if the hemoglobin is normal and your ferritin is in those ranges, that patient needs treatment. But the ferritin cutoff is not always the same for all conditions. For instance, in a patient with heart failure, the European and the South African guidelines use a ferritin cutoff of 300. If you have a ferritin of less than 300 and your saturation is less than 20%, patient's got iron deficiency and needs treatment. In chronic kidney disease, 500. Some guidelines say 300, some say 500. Generally 500 with a SATS, they will allow a SATS as high as 30% and still treat those patients with iron. But now you've got the more difficult conditions, let's say not cardiac failure, not chronic kidney disease, maybe Crohn's disease, like our patient that we saw earlier, where the ferritin is more than 100, the SATS is less than 20%, what do you do now? Well, you can do things like a reticulocyte hemoglobin content, and that will tell you if there is a problem or not. So just as a refresher, ferritin 30 to 100 and transferrin saturation less than 20%, they have anemia of chronic inflammation plus iron deficiency, you can treat. The ferritin is more than 100, but the saturation is less than 20, you need some more tests to be sure, unless the patient's got heart failure or kidney disease, in which case it's also treat. We have to remember that if a patient is over 50, you have to find a cause. Some would now these days, I think, say 45, but you must find a cause either GI or gynecological. These patients need gastroscopies and colonoscopies. The yield of treatable cause is very high. And now treatment. How do we understand this in the light of all I've said. So I've already said if the hepcidin is low, as in simple iron deficiency, you can treat with oral iron. But just remember that all oral irons are not equal. Ferrous sulfate is very cheap, but it's got a lot of side effects, especially gastrointestinal, constipation, abdominal pain, metallic taste, nausea, vomiting, etc. And the adherence is poor, especially because it's got to be taken on an empty stomach. So there are newer formulations of oral iron that are good, not many side effects, better tolerated, and even some that you can take with food without a change in absorption. Remember that pH is important, as I spoke about the pH in the stomach earlier. And if your patient is on a proton pump inhibitor, and that's especially important for you, for those of you working in gastroenterology or general practice, you need to take the iron 2 hours before or 4 hours after antacid. So maybe if you take the iron with breakfast, then leave the PPI for before lunch or something like that. Otherwise, you're going to block the HCl and you're not going to be able to take up the iron. A small glass of orange juice or just eating some oranges can help. And remember that you cannot even try oral iron in patients who've had a partial or complete gastrectomy. It won't work. Enteric-coated iron also don't really work well. Now, something new, well, relatively new, not that new anymore, is that in the past, we recommended daily, twice daily, or even 3 times a day to give the iron, but that is now different. We now know that iron taken every second day is as well absorbed with less side effects. So whatever iron you give, you can rather take 2 tablets, but you take them at the same time, Monday, Wednesday, Friday, and only once a day, not daily, and that works a lot better. The studies in pregnancy is ongoing. It looks like it's probably going to be the same, not published yet, we'll see. But in other arenas, your patient will thank you. They'll be able to stay on the iron longer and have much less side effect. And just for interest's sake, what happens is if you take that first ferrous sulfate, the body responds because of the inflammatory response induced by the ferrous sulfate, which also causes the side effects. The body responds by making hepcidin and blocking iron absorption for the next 48 hours. What can you expect? The cravings will disappear almost immediately. Patients should feel better within the first few days. They will have a reticulocytosis within a week, and the hemoglobin, if anemic, will increase by about 2 grams per deciliter every 3 weeks. And most patients will normalize their hemoglobin within 6 weeks on oral iron. So here you can just see that depending obviously on what your hemoglobin is when you start, how long it will take to get you to normalize it. The problem is that normalization of hemoglobin is just the first step, because the rest of the body is standing at the back of the line. The bone marrow is going to take everything first because it wants to first carry oxygen through red cells. So to replenish iron stores, you're going to need to give iron for another 3 to 6 months at least, and in my experience, sometimes up to 12 months to fully replenish iron stores if you're going to use oral iron. And then cost efficacy becomes controversial or debatable compared to IV iron. What do you do if the hepcidin is high in patients with infection, inflammation, cancer, heart failure, or surgery? Well, oral iron is not going to work. It will be blocked. So you need to use an alternative. And what are these? So there's something new called sucrosomal iron. It's a special preparation that can be absorbed in a different fashion, transcellularly through the M cells in the Peyer's plaques or through endocytosis. And more than 90% of the uptake is hepcidin independent, which makes this a good alternative, but in my experience, does not always work, but it does avoid you from using IV iron. But if used for a long time at decent doses, the price may be very similar to some of the available IV irons. People are often worried about the side effects of IV iron. The reality is that your risk of side effects with oral iron is 2 to 3 times higher. And we do not have the old high molecular weight ions anymore that used to cause high rates of allergic reactions. The ones we have now are generally very well tolerated. Anaphylaxis, very rare. Yes, they can have some reactions like a flushing of the face, maybe a mild sense of chest tightness or a mild wheeze. These are not necessarily anaphylactic reactions. You stop the infusion, you wait 15 minutes, you start slowly again, and you can often continue and complete the infusion. True anaphylaxis obviously is a contraindication when the patients get swollen tongue, throat, drop in blood pressure. That's a different story. So it can often be given very quickly. Some of these preparations can be given in 15 to 60 minutes. You've got a very predictable response, and it's much cheaper than giving blood. So let's go back to our cases and close. I'm at the end. So we said in the first case, this was our patient with our young 25-year-old colleague with pernicious anemia, Helicobacter pylori on PPIs, with a history of menorrhagia. Why is she not responding? Well, because she was getting oral iron, and you remember that we said that patients with autoimmune atrophic gastritis, Helicobacter pylori, often have refractory iron deficiency, meaning they don't respond to oral iron because they can't absorb it properly. She was using the PPIs at the wrong time of day. It was blocking the iron absorption, and the menorrhagia wasn't addressed. Can we attribute the symptoms to iron deficiency if the patient is not anemic? Absolutely. I see this all the time, that patients have all the symptoms of iron deficiency anemia without being anemia. I think I've made it clear that iron deficiency in the absence of anemia must be treated and the cause should be sought. How was she treated? Well, I tried sucrosomial iron in her. Unfortunately, it didn't work. So she was treated successfully with intravenous iron. But because of her underlying conditions, she does need repeat treatment. In her case, fortunately, only once a year. In some patients, it's more often. What do we do with Angelina Jolie and Brad Pitt? Well, Angelina Jolie follows a normal diet. So you can just say, continue with your diet, make sure you eat enough red meat, chicken, and fish. And if that doesn't work, well, then one may need to supplement. And Brad Pitt, who's a vegan, well, unfortunately, he's not going to want red meat. And the other things the egg yolks will block iron, the tea will block iron absorption, the spinach and the tomatoes will not be enough, although the tomatoes may help because it contains vitamin C. So you can advise him to take more of that. But he's probably going to need an iron supplement, as most vegans and vegetarians do. What about case number 3? How do we interpret her iron studies? So we said the serum iron was low. As expected, the transferrin was low. Why is it low? This is the patient with Crohn's disease and the perforated ileum, because transferrin is the opposite of ferritin. So ferritin, we said, is an acute phase reactant. The ferritin goes up with inflammation, whereas transferrin goes down. It's a negative acute phase reactant. So the transferrin saturation here is very useful, 5%. And you can see the ferritin was 159. So what did I do? Well, what can you do? You do a reticulocyte hemoglobin content, which is low, 21. And this patient clearly was iron deficient as well. And with an inflammatory condition, she required intravenous iron. In conclusion, iron deficiency is the most common health problem in the world. Not just your bone marrow, but every cell in your body needs it. You can have all the symptoms without being anemic, because anemia is the end stage. You must find a cause, and if you want to learn more, you can go to my YouTube channel, where you'll find many videos, amongst others 12 videos on iron metabolism, but also many other things related to hematology and medicine. And I just want to thank all these people who have been supportive of our patient blood management programs, and today in particular, the ECHO group from the University of New Mexico, as well as ECHO India, that has been giving us tech support. And I want to just ask all of you to fill in the evaluation form if you think this was worth your while. It's always very nice to get your feedback. If there are things that you want to learn that we did not cover, perhaps please do so. And if you've got any questions, please ask them now or ask them in the chat box. I'd be happy to answer them. I see the first question in the chat box is, what is the name of your YouTube channel? So I'll just go back. My YouTube channel's name is Vernon Louw MedEd. And if you want to become part of our patient blood management group and receive regular updates, you can email me at my UCT address with your details. Send me your cell phone number, as well as your full names and where you work. I always like to introduce any new members of our group, and I'll add you to the WhatsApp group. We won't waste your time with jokes and funny pictures, but we will send you some important updates as they come along in terms of patient blood management and iron. Thank you, Chris, for being co-chair here.
Vernon, if you don't mind, we've got a few minutes for questions.
Sure.
Firstly, I'd really want to thank and welcome some of our sub-Saharan colleagues who've come online from Cameroon, Nigeria, Tanzania, Zimbabwe, Zambia, Ghana. Really a warm welcome to you. We value your commitment and cooperation and colleagueship very highly. And we also would encourage you to send case presentations to us. This is going to be an active part of our GECO group in the new year, where our colleagues in sub-Saharan Africa are going to share the load as far as case presentations are concerned. Just a brief comment, really a masterclass as usual, Vernon. Thank you so much. You take these enormously complex physiological issues and condense them into such easily understandable concepts. As a gastroenterologist, we get a lot of patients who are referred for endoscopic evaluation for an anemia. And I must tell you, the major challenge that we're faced and that we see is actually interpretation of iron studies. It's really something that varies a lot, but is still very poorly understood. And, we often get patients with hemolysis and patients with thalassaemic traits. Now, obviously that takes a hematologist to sort out, and we're developing those skills because you obviously don't want to miss those cases. So emphasizing the physiology and the interpretation of iron studies, I don't think we can do it enough. It's really needs to be it is the major challenge with iron physiology and iron deficiency anemia. Just one point as far as inflammatory bowel disease is concerned, we have a lot of gastroenterology colleagues. It's very important, as you say, to replace iron with parental iron replacement therapy. Our funders are insisting that we give a 3-month trial of oral iron in patients who have active inflammatory bowel disease. This is really absolutely unacceptable. And we have discussed it with them, and they're in agreement that parenteral iron replacement therapy is an absolute indication for patients with active inflammatory bowel disease. And also, apart from improving the symptomatology, also plays a role in the natural history of the disease. I think it's been shown that if you replace the iron effectively, it will not only improve symptomatology, but will impact the natural progression of the disease. So that cannot be highlighted enough. But thank you very much.
Thank you very much, Chris. I see there's a question here from Igembe Nkandala. I hope I pronounced that correctly. Thank you very much for your question. So the question is, are any thoughts on IV versus oral iron following gastrointestinal bleeding with respect to cost effectiveness and compliance? So, okay, so a couple of comments there. Let's start with the reason for the bleed. If you have an ulcer in the stomach, or you've got any active inflammatory bowel disease, giving ferrous sulfate will worsen the symptoms and can actually worsen the inflammation. And Chris can help me. I'm not a gastroenterologist, but that's what he's taught me. But it's a problem if you give something like ferrous sulfate in that circumstance. Secondly, IV iron gives you immediate replacement of all the iron lost, and you are sure that you've got it on board. And as in, if you give oral iron, 1/3 to a half of the patients will not respond or not respond adequately. And when they respond, it's going to take a long time, and you may not have that time. And that's where I much prefer intravenous iron, because it's a lot cheaper. I've got a slide in another presentation. I can maybe show it at a next occasion, where I've compared the prices of blood with intravenous iron. But blood is multifold more expensive in most instances. So IV iron is a much quicker way to replace that. You obviously want to stop the bleeding source, but there are cases where your hemoglobin, due to the blood loss, also in menorrhagia, is unable to respond fast enough with oral iron, because you're losing more than what you are giving. I hope that helps.
There's a hand raised from Masheko Sushedi. Masheko, if you want to unmute and ask your question.
Vernon, thank you so much for that. I thoroughly enjoyed it. As you say, one can never go enough over these cases and just understanding iron physiology. My question is, what is the mechanism for pica in iron deficiency?
Yes, so that is very poorly understood. It seems to be an effect on your appetite center in the hypothalamus, Mashiko. And it's something that is of great interest to me. We've actually published a study many years ago, and maybe I can just use this opportunity to share a nugget from that study that we found very interesting. So traditionally, we are taught that pica refers to a craving for non-food substances. And as you are all aware, the most common forms is a craving for soil or dust, geophagia, and or a craving for ice or cold fluids, pagophagia. But what we know is that there could be a craving for many strange things, like burnt cigarette stumps, paper, anything you can imagine. But what we found in our study is that many people have a craving for an excess craving for foods, not just non-foods. One patient was eating a whole bag of tomatoes a day. One was eating 2 loaves of bread a day. One was eating macaroni by the buckets. So interesting, and a very common craving that I find in my practice is chocolates and sweets, some strangely enough, like the one patient that I showed. So the cravings are not just non-foods, it's also foods. And if you ask patients about it, and they're often very shy to talk about it, but you'll find that it's the best thing that you can ask from history, the most specific almost, because 2 out of 3 patients with iron deficiency will have cravings. And we often say that pregnancy causes pica. I don't believe a word of it. I believe it's the iron deficiency in pregnancy that causes the cravings, and which is present in up to half of female pregnant women. So there's a question here from Yasmin Goga. Hello, Yasmin. Nice to see you again. She says she thinks we need to re-educate our doctors, especially our GPs and our obs and gynae colleagues. I had the great privilege, Yasmin, to speak to 160 obs and gynae colleagues just 2 weeks ago. And I've done this sort of presentation every 2 weeks on average this past year. So we've been able to reach many thousands of colleagues, about which I'm very excited. Do we have South African data of iron deficiency in our communities, and how food fortification has impacted this at all? So do we have data? We've very little data, unfortunately. I've shown you a study from the Western Cape in the beginning that showed that 56% of females in the Western Cape are iron deficient in that study, and that combined private and public sector. We don't have that many studies. One of my PhD students she's from Ghana. She's now already completed her PhD. She worked on iron deficiency amongst rural communities in Ghana, where up to 90% of people living in very poor areas are iron deficient. Has food fortification impacted this? I'm sure it has helped, especially in infants, but it's clearly not enough, because we still see a lot of problems. I think food fortification has done more for folate deficiency, which is hardly ever seen. but food, iron deficiency still remains very common. Sounds like we are, everybody seems to know all the answers now. So yes, I'm looking forward to next year. I think I was privileged to do a similar thing with Mashiko in a previous session where we tackled some other aspects of this. And there's so many things to talk about and so many things to get excited about. So we can look into some other details next year, perhaps if there's the opportunity. But from my side, again, thank you everybody for making the time this time of the afternoon on a Thursday to come, for Chris for co-chairing, for Karen, for Cheryl, for organizing this, to the ECHO and group in New Mexico and ECHO India, again, for your technical support. We really appreciate it. So have a lovely evening, everybody, and bye-bye.